It is my pleasure to be with you, following Professor Boslini for fantastic lecture about reverse shoulder prosthesis. And my lecture will be about arthritic shoulder arthroplasty. The objectives of our lectures: indications of for shoulder arthroplasty, shoulder prosthesis options, the agony of choice. For becoming a shoulder arthroplasty surgeon, you should know the biomechanics of shoulder arthroplasty and how to prepare the patient for preoperative planning, and the technique, and lastly, how to avoid complications. There are many indications for shoulder arthroplasty. Many. First, we have displaced proximal humeral fractures, which is not amenable for fixation. Also, primary arthritis, post-traumatic arthritis, cuff tear arthropathy, inflammatory arthritis, shoulder girdle tumors, osteonecrosis, and failed shoulder arthroplasty. This is the whole indications of shoulder arthroplasty as general, not specific to type of prosthesis. In our lectures for arthritic shoulder arthroplasty, we have primary indication of glenohumeral arthritis that is not successfully managed surgically in conjunction with intact rotator cuff. Other indications include inflammatory arthritis, advanced osteonecrosis with glenoid involvement, and post-traumatic degenerative joint disease with proximal humerus malunion. We have many shoulder prosthesis options, including whether hemiarthroplasty or total shoulder arthroplasty or reversed shoulder arthroplasty. Actually, reversed shoulder arthroplasty was covered by our professor, and here we will talk about total shoulder arthroplasty. As a historical review, we have three major generations of anatomic humeral components based on their design. The first generation of shoulder arthroplasty was monoblock implant with different size of heads and different length. Then we get a second generation, which is modular with variable head diameters. So we have two pieces, stem and head. Third generation, which is modular and adaptable. So we have multiple head diameters. The prosthesis stem has variable neck shaft angles, inclination, and also we have head can be placed in varying degrees of posterior and medial offset. So we have eccentric head, thereby allowing a nearly perfect replication of patient native anatomy. Lastly, we have Aqualis fracture prosthesis, which is specific for trauma, and this gap for bone grafting. And also this portion was hydroxyapatite coated for better replication of the proximal humerus anatomy. In this case, we have arthritic shoulder, primary glenohumeral arthritis, and as options for arthroplasty, we have anatomical shoulder arthroplasty. Also, we have what's called ascend prosthesis or resurfacing prosthesis. Anatomic shoulder arthroplasty needs two prerequisites for good result: intact or repairable rotator cuff. So in cases of irreparable rotator cuff, we haven't to do anatomic total shoulder arthroplasty, and we shift to reverse shoulder prosthesis. Also, we should have adequate glenoid bone stock for the prosthesis. Another option is ascend total shoulder arthroplasty, which is cementless stem, short stem, and glenoid component. As regard resurfacing shoulder arthroplasty, we have advantage of bone preservation, no need for straight humeral canal to adequate along stem, but we have a disadvantage of glenoid exposure, can be more difficult because the humeral head is not resected. So in this case, with malunited proximal humerus and arthritic shoulder, it is difficult to introduce a traditional long stem. So the resurfacing shoulder arthroplasty can solve this problem. On the other side, the glenoid component, we have glenoid resurfacing prostheses. All are polyethylene, cemented, curved back design. They can be fixed by pegs, such as in this photo, or keel. On the other hand, we have glenoid biologic resurfacing developed to address the young patient with disabling arthritis. So we have allograft tendo Achilles promoted to reshaped to allow to be formatted with the glenoid, and then fix it to the glenoid to act as a glenoid component. Another technique is what's called Ream-and-Run Procedure. An attempt to achieve glenohumeral stability by spherical reaming about the center line of the glenoid to correct eccentric wear and minimize the potential progressive erosion and instability that has been reported with humeral arthroplasty alone. So in this case, we have eccentric glenoid wear, and after reaming, we have centered glenoid, and this will add stability to hemiarthroplasty. So we have agony choice. This from photo from Museum of Schoen Clinic in Munich. As we see, there are many options of prosthesis. The agony of choice, we have many different options. Depends on to choose an prosthesis, you have to check the etiology of the pathology, the bone stock, whether humeral side or glenoid side, the rotator cuff nature and the muscle status, and age and activity of the patient, and finally compliance of the patient to the prosthesis. As regards arthritis, total shoulder arthroplasty, in contrast to hemiarthroplasty, may result in less pain, better fulcrum for active patient, better strength. So it is preferable for arthritic shoulder to choose total shoulder arthroplasty. But as we said before, we have two prerequisites: intact or repairable rotator cuff and adequate glenoid bone stock. For becoming a shoulder arthroplasty surgeon, first we should know that the shoulder is not a hip. As we know, both joints are ball and socket, synovial joint, but the shoulder is retroverted joint, retroverted both humeral component and glenoid component. Whether hip joint is antiverted joint. The hip joint stability mainly depends on the bone stock, while shoulder arthroplasty mainly depends on soft tissue stability and coordination. So the articular surface of the humeral head with respect to the bicondylar axis show humeral head retroversion from 30 to 40 degrees, and the neck shaft angle, as we see, 45 degrees. The distance between the center of the head and the center of the medullary canal is defined as humeral head offset. So we have two offsets, medial offset and posterior offset. So the center of the head is medial to the center of the medullary canal and also posterior to the center of the medullary canal. And this is a very important technical point. In this prosthesis, this is anatomical prosthesis, and this is the stem, long axis of the stem, and this is the center of the prosthesis. So it is medially and more posterior. To address the total shoulder arthroplasty, we should have an intact rotator cuff, whether supraspinatus, infraspinatus, and teres. And also as anterior stabilizer, we should have intact subscapularis. The rotator cuff muscle compresses the humeral head against the concave surface of the glenoid and the labrum, thereby allowing the concentric rotation of the humeral head. So the rotator cuff acts as a stopper for elevation, and then the deltoid acts as elevator. This concept, termed concavity compression, is thought to be important at both the mid-range and end range of the glenohumeral motion. Also, there is some normal glenohumeral relationship should be in mind when doing shoulder arthroplasty. The important distance is head tuberosity distance. A line from the head and the line from the tuberosity. This distance is about 8 to 10 millimeters. Also, the lateral glenohumeral offset, and also the glenoid offset, which is from the coracoid base to the glenoid axis. So when there is decreased offset in the glenoid, the fulcrum will be disturbed. Also, when the lateral glenohumeral offset is decreased, the fulcrum of abduction will be disturbed. So to proceed for total shoulder arthroplasty, you have to respect these relationships. In order to do total shoulder arthroplasty, you have to imagine the biomechanical goals of the shoulder arthroplasty. The four main characteristics of a well-functioning shoulder are motion, stability, strength, and smoothness. These components are frequently compromised in conditions requiring shoulder arthroplasty. So in arthritic shoulder, you have decreased motion. In unstable shoulder, you have instability. The strength and the smoothness are disturbed in arthritic shoulder. And it is the goal of the surgeon to restore each of the elements to normal. The motion of the shoulder after arthroplasty is achieved by the following. So when I do a total shoulder arthroplasty, I should keep in mind these steps to regain the motion. So I should release adequately the contracted soft tissue, especially the subscapularis. And in this view, you have contracted soft tissue and adhesions posterior to the subscap, and this after release, and this a clinical photo of supraosseous release from the anterior subscapularis fossa. Another issue is resecting the blocking osteophyte, so increase the rooming of the shoulder and so will increase the motion. Lastly, you have to select a proper sized prosthetic component, not a large component to avoid overstuffing or a small component to impair the stability of the prosthesis. The stability of the glenohumeral joint is achieved by proper sizing and the position of the prosthetic component, proper balancing of the soft tissue, whether anterior, posterior, superior, inferior. The strength is best when the joint is not overstuffed, providing optimal length tension relationship of the involved muscles, especially deltoid and rotator cuff muscles. So in order to maintain the length to avoid deltoid overtension, the rotation and the retroversion to avoid overtension of the rotator cuff muscles. Smoothness of the articulating component is assumed with arthroplasty, but there must also be smooth gliding surfaces of the humerus and the cuff under the coracoacromial arch and around the glenoid. Now we shift to preoperative planning. As our professor said, is paramount of success of the procedure. Use of standard radiograph and the implant template help to establish the proper position of the humeral implant and to alert the surgeon to the possible problems. CT is a quite helpful for evaluating substantial glenoid erosion and increased glenoid retroversion. So in any case of shoulder arthritis, you have to do an MRI, X-ray first, MRI and CT. And here in CT, we can imagine the degree of retroversion of the glenoid, both of the glenoid as regards the scapular spine and the anterior posterior points of the glenoid. Then the angle is about 30 degrees of retroversion. Classification of arthritis of the glenohumeral joint: type A, concave; type B, biconcave; and type C, dysplastic, as our professor said. MRI for evaluation of soft tissue, especially rotator cuff tears, defects, and the muscular atrophy and fatty infiltration, may alter the decision and do a shift from anatomic shoulder arthroplasty to reverse shoulder arthroplasty if there is any problem of the rotator cuff. As regards technique, we have the approach, the humeral component, and the glenoid component. Step by step, the horseshoe technique of the shoulder is the deltopectoral groove. In a beach chair position, this is the deltopectoral approach, and this is the deltopectoral interval. And here, this is the pectoralis major. You have to resect some fibers to get a wide view. And here, these are the three sisters, 2 vein and 1 artery. You should ligate them. And then this is the subscap. Here, this is a C suture in subscapularis. And then we cut subscapularis just medial to the lesser tuberosity, gently. And with cutting, you have to externally rotate. Then we have to release the subscapularis, as traditionally we have limited rotation in arthritic shoulders. So we have to release, get room of the subscapularis and rotator cuff, subperiosteal elevation of subscapularis, and resecting osteophytes, and then templating of the humeral side. And then the articular surface of the humeral head is resected in plan with the inside rotator cuff insertion at the level of the greater tuberosity. In retroverted position, 10 to to 30 degrees. Now we get a template or trial processes for the humeral component, and now we shift to the glenoid component after insertion of fukuda retractor, and this is the identification of the glenoid and resecting the labrum, and then templating of the size of the glenoid, then reaming, and then you can choose whether to insert a keel prosthesis or big prosthesis. And cementation of the glenoid component. As we said, all polyethylene, all cemented. And lastly, we implant the prosthesis, and then closure of the subscapularis through the transosseous sutures of the proximal humerus. This is the prosthesis. In order to avoid complications, you have to know what's the possible complications. We may have intraoperative complications, whether nerve injury, mainly axillary nerve injury or musculocutaneous nerve, vascular injury, humeral shaft fractures. Postoperative complications may include stiffness when you don't release adequately the soft tissue, rotator cuff tears when you overstuffing the prosthesis or do excessive retroversion or anteversion, aseptic loosening, periprosthetic humeral fractures, delayed dysfunction, and postoperative infection, prosthetic instability, and glenoid problems. To conclude, we have many indications of shoulder arthroplasty. There are agony of choices of prosthesis. Good preoperative planning and adequate technique gives us best results. Thank you.
Thank you so much, Professor Emad Zayed, for this interesting talk about shoulder arthroplasty. Now we will go on to the Professor Ahmed Sheikh for moderating this session. Dr. Ahmed.
يا فندم شكرا جزيلا دكتور عماد على التوك الجميل ده اللي كان فيه بعض البيزكس اللي كنا محتاجين نسمعها فعلا عشان الناس تبقى اورينتد معانا بالاوبشنز different problems. في سؤال هنا هو سؤال عميق صراحه ومن السيناريوهات الكومبليكيتد، يعني انترا اوبراتيف جلينويد فراكشر افتر ريمينج. سيناريو يعني واحد بنتمنى ما حدش يشوفه يعني، بس هو بيسأل لو حصل حاجه زي كده فبتعمل ايه يعني، وعملت البيس بليت وحطيت سكرو او الانستيبل فيكسيشن، فايه الاوبشنز؟ هو طبعا بيسأل عن ادنج سيمنت للبيس بليت، بس طبعا اعتقد هو احنا لو بنتكلم في حاجه يعني بيس بليت بسكروز فهو ده اصلا ما فيش فيه سيمنت، بس هو بيطرح السؤال بشكل عام. فرايح حضرتك في سيناريو زي ده من السيناريوهات الصعبه اللي يعني اكيد الواحد ممكن يقابلها بس نادرا يعني.
بص هو اكشولي حصلت وانا في المانيا مع بروفيسور جولكا حصلت مع مره ان حصل فيه جلينويد فراكشر.
تمام.
وهي ديلت ويز ان هي كانت ميجور anterior rim fracture. He fixed the fracture by two screws anterior, and then implant a cemented prosthesis over the screws after fixation of the screws. Another case, he bought an allograft for reconstructing the anterior glenoid rim also in two cases, in another case. So you can, if it is fixable, you can fix directly. If it is just defect, you can replace by allograft.
تمام.
Then you get a prosthesis over this.
تمام. هو مش شايف اسئله دلوقتي، بس هو في سؤال برضو مهم يعني كنا من المحاضره الاولى، وهو سؤال موضوع الهيمارثروبلاستي فيرسس الريفيرس في في حالات الكوميونتي بروكسيمال هيومرال فراكشر. طبعا هم ما هماش على قدر المساواه خالص، بس بنتكلم من ناحيه الافيلابيلتي والكوست هنا في المستشفيات بتاعتنا في مصر، وحتى الايز اوف ابلكيشن بالنسبه يعني للاكسبرتيز ان ريفرس ده بيبقى ده يعني ممكن يبقى عايز حد مور اكسبيرينس. ف لو حد اولد ايج وبتاع وايكوفوكال ان يتحط له الاثنين، رايح حضرتك يعني هل هيمي ارثروبلاستي وانت قلقان من جلينويد ايروجن بعد كده، ولا لا ريفرس من الاول ونبقى احنا مش قلقانين من اليونيون والكلام ده، مع المشاكل او الريستريكشنز بتاعت الاسعار بتاع الامبلانت والسوق في مصر؟ من خبره حضرتك كده رايك ايه في النقطه دي؟
بص يا ابو حميد، هو من الاول خالص any proximal humeral fractures dealt with osteosynthesis. If it is not amenable for osteosynthesis, we will go for arthroplasty. First option of arthroplasty is hemiarthroplasty.
تمام.
If it is not amenable for hemiarthroplasty, whether for very osteoporotic bone, old age, impaired rotator cuff, we shift to reversible prosthesis. So the reversible prosthesis is the second option after hemiarthroplasty.
تمام.
But as a prerequisite for hemiarthroplasty, you should have an intact rotator cuff and adequate greater tuberosity bone to allow for healing. The hemiarthroplasty depends on مش فكره البروسيسز، لا هي فكره ان انت تلاقي هيلينج للتوبروستيز بعد كده. كل الكومبليكيشنز اللي بتحصل من الهيميارثروبلاستي due to malunion non-union of the tuberosties. فالمشاكل كلها بتاع الارثروبلاستي بتحصل من التوبروستيز. فلو عندك مشاكل في التوبروستيز مش هتأدي لك الغرض، shift to reversible prosthesis from the start.
تمام.
او بقى لو عندك عيان malunion neglected proximal humeral fractures وكتير قوي عملنا لهم هيمي ارثروبلاستي، الريزلت بتاعتهم very bad. So for me from start reversible prosthesis for neglected proximal humeral fractures.
تمام دكتور عماد، تمام كده يا باشا. another question بيسأل عن wound breakdown after the treatment. يمكن سؤال مفتوح عن الwound breakdown surgical site infection ممكن او حاجه، بس يعني رأي حضرتك في النقطه دي، او الشولدر كاريا والابروتش ده كابروتش، هل من الحاجات الكومن اللي بيحصل فيه مثلا wound breakdown او حاجه او كده؟
لا، زي ما احنا عارفين ان الشولدر ده very vascular joint، الهيلينج فيه عالي جدا جدا. انت جاست بتعمل سبليتنج، مفيش اي يعني ما بتعملش اي disturbance لاني فاسكولاريتي. فعلى ما اعتقد ان يكون يحصل wound بريك داون otherwise infection it is very difficult. فالهيلينج فيه عالي جدا، انما هو لو حصل فيه انفكشن وده انسيدنس قليل شويه as regard الني والهيب، فممكن يحصل wound بريك داون. بس فور مي ما حصلش خالص wound بريك داون otherwise الانفكشن.
تمام. هو there is no more في سؤال ماشي جه دلوقتي in complex proximal humerus fractures لو عملنا reverse total shoulder arthroplasty isn't it important to restore tuberosity repair؟ هو سؤال عميق وحلو. هل احنا لما بنعمل في البروكسيمال humerus fractures reverse خلاص بقى بنضحي بالتيوبروستي بروتيتور كاف ما احناش عاوزينهم يعني، ولا برضو بنبقى بنحافظ عليهم وبنخيطهم وبيهمنا الريبير بتاعهم؟
بص، انا شفت الادفانس بتاع الريفيرس شولدر ارثروبلاستي من اول ما كانوا بينجلكت خالص التيوبروستيز، وبعدين في الاخر لقوا ان لا، ان التيوبروستيز شود بي مينتيند. ففي كل الحالات دلوقتي حاليا لو في تيوبروستي، يعني في ايا كانت الفانكشن بتاع السيتويشن بتاع التيوبروستي، it is very important to regain التيوبروستيز. الانتيريور تيوبروستي مهمه جدا جدا في الانتيريور ستابيليتي، والجريتر تيوبروستي مهمه جدا 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 في الاكسترنال روتيشن. هو كل مشكله الريفرس بروسيسز ايه؟
ليميتد اكسترنال روتيشن.
ليميتيشن في الاكسترنال روتيشن. هو بيعمل ابدكشن كويس لان الدلتويد شغاله، انما مشكلته انه ما فيش عنده اكسترنال روتيتور. فكانوا بيشوفوا اي فايبرز موجوده من التيرز والانفراسباينيتس عشان خاطر يمبلانت في الجوينت في البروسيسز، بحيث ان هو يمينتين some motion of external rotation. فبالتالي ان انت ترجع الاناتومي ايا كان السيتويشن وايا كان نوع البروسيسز، ما تعتمدش على البروسيسز، دايما اعتمد على الاناتومي. ففي كل الحالات whenever you can restore التيوبروستيز بليز دونت مس.
كلام جميل جدا يا دكتور عماد، واجابه فعلا مهمه جدا. اعتقد ما فيش اي اسئله ثانيه. بشكر حضرتك مره ثانيه على التوك الجميل،
وسعيد جدا جدا سعيد جدا
نشكر حضرتك يا
بصراحه
دكتور عماد، شكر كبير
حبيبي
على
دكتور
تواجد
محمد بيه
حضرتك
والله.
معانا النهارده.
ربنا يخليك.
ختام المسك للكورس النهارده يا فندم.
حبيبي يا بيه والله، فرصه سعيده جدا.
ربنا يكرم سيادتك يا بيه.
والله يخليك، الله يكرمك، الله يخليك يا بيه، الله يخليك. فرصه سعيده جدا وبالتوفيق ان شاء الله، وحاجه يعني حاجه ممتازه جدا. ربنا يخليك.
ونامل ان احنا نشوف سيادتك معانا في الكلينيكال ميتنج بتاع الجمعيه يوم الخميس ان شاء الله.
ان شاء الله باذن الله
ان شاء الله. نتشرف
كويس
بسيادتك
ان حضرتك منبه علينا على طول
نتشرف بسيادتك يا فندم.
ربنا يخليك ان شاء الله باذن الله.
الله يخلي حضرتك. شكرا جزيلا اخينا الحبيب الفاضل استاذ دكتور عماد بيه زايد طب الازهر على الفيري انترستنج توك. وده ختام